Uh, my case today is a case related to TAVI. The title is PeriTAVI Conduction Disturbances. A 72-year-old male non-hypertensive dilated non-ischemic cardiomyopathy and end-stage renal disease in regular hemodialysis using a left-arm AV shunt. The patient developed recurring chest pain with minor exertion. 2D echo showed severe low flow, low gradient, ischio-calcific aortic stenosis, and underlying reduced LV ejection fraction with a series of the following echocardiograms. I will show the echo performed to the patient. The first one showed a LV ejection fraction 28% and a trisinus tricommissural aortic valve, tricuspid aortic valve, thickened and heavily calcified leaflet tip and body, and estimated mean and pressure gradient 81/44 millimeter mercury, peak velocity 4.5, aortic valve area by continuity equation 0.9 centimeter square and indexed 0.5 centimeter square per meter square, and mild aortic regurg. And estimated aortic valve annulus diameter 27 millimeter. The aortic root was normal. This is against the echo performed in the structural intervention cardiologist clinic, which showed tricuspid aortic valve and mean pressure gradient 20 millimeter mercury and mild aortic regurg. So he scheduled the patient for low dose dobutamine echo, which showed severe low flow, low gradient aortic stenosis with increased to peak pressure gradient to 63 and mean pressure gradient to 41 millimeter mercury. According to ASC 20 and 21 guidelines, for valvular heart disease, the patient was diagnosed as severe aortic stenosis and fall in the category of low flow, low gradient aortic stenosis with reduced ejection fraction. Management of severe aortic stenosis, the heart team evaluation calculated the Euroscore for the patient. The Euroscore was 16.3%, which is more than 8%. So the patient was candidate for TAVI because it's high risk for SAVR and suitable for transfemoral TAVI. This goes along with a lot of clinical, anatomical, and procedural factors that influence the choice of treatment, which favors TAVI, like high surgical risk. As we said, the Euroscore was very high, and older age and severe frailty. Another anatomical and procedural factor, TAVI was feasible via transfemoral approach. High likelihood of severe patient prosthesis mismatch because the aortic valve area was 0.5 centimeter square per meter square body surface area, and absence of other factors that favors SAVR, like chest deformity, bicuspid aortic valve, and surgical aortic valve replacement, and absence of other cardiac conditions requiring intervention. 12 lead resting ECG pre-procedure showed a QRS duration 146 millisecond with a typical non-classic left bundle and PR interval prolongation 222 with monophasic R in lead 1 and AVL and monophasic S in V1. The coronary angio report during the procedure showed non-significant lesions. I will show the video. I hope it works. And TAVI report, the patient implanted for a mi-valve. This is a CE market valve, balloon expandable valve, was 27.5 millimeter. This is a video of TAVI implantation. First, the coronary angio showed non-significant lesions, atherosclerotic vessels. Okay. This is a big tail catheter in the aortic root for injection of the aortic root, and the delivery system of the mi-valve. As I said, it's a balloon expandable valve across a super stiff wire, and a temporary pacing via the right jugular axis for rapid pacing during deployment of the valve. Okay, here the valve is deployed and the delivery system withdrawal, and there is a injection also with the big tail now. Okay, We can note a slight deeper implantation of the valve, which could be related to the conduction disturbance happened after the implantation. This is the injection after deployment of the valve. Okay. A chronological series of 12 lead resting ECG post-TAVI showing progressive conduction disturbances. This is the ECG immediately after the procedure, which showed a right bundle branch block, BR interval, the QRS duration 164, BR interval 238 millisecond, and left axis deviation trifascicular block. This is, was followed by this ECG after several hours of the procedure, which showed the like the baseline ECG with QRS duration 138 millisecond, also first degree heart block and left axis deviation. The patient, from the previously mentioned points, that we can predict the factors that predict permanent pacing after TAVI, the right bundle branch block, the BR interval prolongation. This is the checklist in the guidelines. The older age, the male-sex, a lot of factors predict the permanent pacing after TAVI. And the procedural factors, it was not a self-expandable valve, it's a balloon expandable valve, but we noticed a deeper valve implantation as stated by the structural cardiologist that said it might be a slight deeper valve implantation that result in these disturbances later. The patient was discharged without further monitoring. 2 days later, was presented to the ER department after a witnessed syncopal attack in his home with the following series of ECG during CCU readmission monitoring. This is the first ECG in the ER. We can appreciate the morphology of the QRS complex like the ECG after TAVI. Right bundle branch block, marked BR interval prolongation, and left axis deviation trifascicular block. This was at around 2 a.m. This is followed by this ECG, which was performed during, after a syncopal attack in the CCU, like 4 hours after the admission from the emergency department. We can see a high grade AV block with ventricular escape rhythm. This is 3 minutes after this ECG. It was resolved and resulted in this ECG with a right bundle branch block and also a trifascicular block. A temporary transfemoral transvenous pacemaker wise was inserted, as we can see in the REO and LAO view. This is the based ECG after placement of the temporary wire with RV only pacing. According to 2021 guidelines on cardiac pacing, the patient is a candidate for permanent pacemaker implantation. And he is a candidate for CRT rather than RV pacing because of the underlying HFrEF, even regardless of the NIA class, and this is a class 1 level of evidence A. And our choice was for this patient CRTB, not CRTD, because of many factors that in favor of choosing CRTB, like he was a non-ischemic cardiomyopathy patient, major comorbidity, poor renal function, he was an end-stage renal disease patient, and advanced age. So our choice and shared decision-making was for CRTB. I will show the procedure now. It's working video. First, we, as Dr. Musa said, we implanted the RV leads in a high septal position. And we also secured by the temporary pacing lead. This is the introduction of the delivery system for the CS lead immediately after placement of the RV lead with a good pacing threshold. We can appreciate here the left amplets, catheter, and a trauma wire over a trauma wire for cannulation of the CS. Here the introduction of the delivery system after cannulation of the coronary sinus over the left amplets catheter. Um, yeah. Now the delivery system introduced inside the CS body, and we will withdraw the amplets and the trauma wire. This is our injection in the coronary sinus. We can appreciate here the great cardiac vein or anterior cardiac vein, and we can appreciate the lateral or anterolateral branch, the anterior cardiac vein, and most probably a middle cardiac vein. And if we closely look, there is a retrograde filling or a filling of another vein, which will be showed later, or across the border of the heart. Very faint now. Here we can see the from the lateral, from the injection from the coronary sinus body to the lateral branch, there is a filling of a vein here. First of all, we try to cannulate using as a subselector the lateral or anterolateral branch, which was very difficult and very tricky, and we couldn't able to cannulate or introduce our PT2 wire in this branch. So we get back more proximally, and we did another injection using the subselector for trial of cannulation of this branch, which can be considered posterolateral branch. Then we introduce the subselector selectively to the tributary, and delivery of the quadripolar leads, and all the configuration was very bad. Threshold more than 3 volt. No for M1 and M2. Like 3.5 volt at 1 millisecond pulse width. So we didn't accept this measurement at all. We tried back to cannulate the great cardiac vein and crossing the Vissian's valve. But even it was very difficult. I will show the REO view now. Very tiny, very difficult. So we did another injection and found this huge, gigantic vein, tributary related to the middle cardiac vein, and feel like this. دكتور مازن بقى هيقول لنا بعد كده ده اسمه ايه؟ ده اكسترا كاردياك، ساعات بيسموه دبل بارل سي اس.
Extracardiac vein, supradiaphragmatic extracardiac vein. That was one case. I read it only in the Mayo Clinic case عارفه الكتاب ده يا لميا طبعا كنا بنذاكر منه. One case reported this.
Yes.
And this should be reported in literature يا صلاح.
Only isolated cases. We have like 3 cases from like this vein, and cannulation of this vein also resulted in a very good pacing threshold. This is the introduction of the quadripolar lead, and we obtained all the measurements less than 1.5 in all configuration. No phrenic nerve stimulation. This is the final after implantation of the RV lead and doing the traction test. This is the final shape here, the PE view. Yes, this is the final. And we look now to the ECG after implantation. This was simultaneous RV and LV pacing with QRS duration 170. We don't accept these numbers, so we do a lot of work on the programmer, changing configuration till we achieved 166 milliseconds with evidence of LV pacing. This is RV only to ensure the septal, to see the septal capture of the placed RV lead. We did an offset 60 millisecond, obtained 160 millisecond QRS duration, 20 millisecond LV offset, 174, and finally LV to RV offset 40 millisecond with QRS duration 144 millisecond with good evidence of LV capture. Take-home messages: the development of new transcatheter heart valve has led to reduction in significant perivalvular leaks, but with a milder impact on the rate of permanent pacemaker implantation after TAVI. One of the main challenges in TAVI feed will be the reduction of advanced conduction disturbances needing permanent pacemaker implantation. High-grade AV block remain one of the most common complications of TAVI. Delayed high-grade AV block may be particularly dangerous as it commonly occurs after discharge in a vulnerable and often frail elderly population with risk of falls, syncope, and even sudden cardiac death. So, a strategy of routine remote ambulatory cardiac monitoring for identification of conduction disturbances and to reduce the unplanned pre-discharge post-TAVI must be feasible and sometimes and frequently leads to permanent pacemaker implantation, which was shown in the redirect TAVI study. Ostial injection can show a double barrel coronary sinus. Always demonstrate that the postlateral venous branch may arise selectively from one barrel or double barrel coronary sinus. This anomaly of coronary sinus should be considered when there is apparent angiographic lack of posterolateral branches. Comprehensive understanding of coronary venous anatomy and its anomalies is becoming interestingly important as more biventricular devices are being placed. Catheter manipulation and re-injection of contrast may be needed multiple times to ensure accurate visualization of the coronary venous system, as we shown in our case, multiple injection till we found our target. An EP specialist should be an active member in multidisciplinary heart team evaluation panel and involved in decision making before, during, and after TAVI. Strict monitoring and analysis of minor ECG changes PeriTAVI is of utmost importance and prevent life-threatening events. Thanks for listening.